Hello, and we start now the second webinar from this UCARE LevelUp program. I am Ana María Giménez-Arnau. I'm talking to you from Barcelona, Spain, and I will share with you a very nice welcome. The second webinar, the first was successful, but the second one, I think it will be also great because it will face an important item, which is the patient's burden of the disease and what the word burden means. Because if we try to translate burden to Spanish language, for example, as carga, there is not enough meaning in the word as it is in English. Then how burden means will be explained for these experts in urticaria. And because we are in a worldwide network, we have the honor to share our webinar with 3 experts coming from Europe, from South America, and from North America. The first, Margarida Gonçalo, belongs to the University of Coimbra. She's an immunologic expert in contact dermatitis, in atopic dermatitis, and even in urticaria. Luis Felipe Ensina is an allergology. He is located in Sao Paulo. You know him very well. He is the head from the UCARE networks in Brazil. And Mosh Benha Sosha, he comes from Montreal, and he will address one of the most important issues today. Is a novelty. We have in the program this novelty because Margarida will focus on the burden of the disease for our patients, the global burden of this disease on the chronic urticaria patients, mainly looking to the patient. And Luis Felipe Ensina will go through the burden of the disease in the society, but which is the burden of the disease in the pediatric patients and their families is not a common subject that is addressed in our meetings. Then I don't need to explain what's urticaria. Urticaria is a muscle-driving disease. The elemental lesion is a cutaneous lesion, which is fleeting in nature, with its itching, which is gross, which is really very despair the quality of life, and also with angioedema, and is very frequent in all of the world. But the overall life chronic urticaria prevalence is around 4.4%, and the point prevalence 0.7%, and the prevalence in the different areas in the world: 1.5 in Latin America, 1.4 in Asia, 1.5 in Europe, or 1.5 in America. Probably we'll need to be more deeply understood and studied, and the numbers will be a little bit different. One of the causes, one of the things that is important in the burden of the disease is the delay in the diagnosis, which is very well recognized, and really makes that the correct messages to our patients in order to explain how is the disease and avoid comorbidities. At 30% of them psychiatrics still is from 3 years in Central and South America, 2 to 4 years in Western Europe, maybe 2 years in Canada, more than 6 weeks to get an appointment with a physician in 45% of the patients who suffer chronic urticaria. Maybe in Japan is a little bit better, but the delay in the diagnosis, even nowadays, after many years that we've spent explaining urticaria around the world, it still is there, and the drugs are not accessible for everyone. Then we will start, and each speaker will have 15 and 10 minutes, and after we'll have 15 minutes for question and answers. And I hope we can have a good discussions, because the subject is to show the problem, but also to make some solutions. Thank you to Novartis for the sponsorship, and let's continue with the following speaker.
So I want to thank you for the invitation to participate in this webinar, to really try to clear the word burden, what burden means for these patients who suffer from chronic urticaria and what we can do to reduce it. I am coming from Coimbra, Portugal, and these are my possible conflicts. This is my old university that has more than 700 years now. So I will speak what is the real burden of chronic urticaria among all dermatological and even non-dermatological diseases. Then I will go to the factors that really influence disease burden. What is the impact of chronic urticaria on health-related quality of life for patients and also families and friends that also suffer from the urticaria of your patient? And then second part, how can we reduce this burden? First of all, I want to share with you this study that was conducted a few years ago by the Institute of Health Metrics and Evaluation, funded by the Bill and Melinda Gates Foundation, where they looked at about 200 countries and more than 300 diseases. Of them, 15 were skin conditions, and they evaluated what is called the DALYs, or disability adjusted life years, or years that were lived with disability, including years lost to the disease. And when we look at this, the whole study, if we look at skin diseases represent 8th leading cause of global DALYs. And if we exclude diseases that have mortality, skin diseases occupy the 4th place. And they represent almost 2% of the global burden of diseases as a whole. And if we separate them for several subtypes, dermatitis comes first, but dermatitis is atopic, contact, seborrheic dermatitis, so all kinds of dermatitis. Then we have acne vulgaris. For me, this was a kind of a surprise, but then we have immediately after urticaria and psoriasis, almost with the same percentage of this global burden of diseases, which is quite significant if we consider all the possible diseases we have in the world. And in this study, they found that urticaria was responsible for 67 years of these disease years lived with disability per 100,000 persons, which is really significant and very similar to psoriasis, as you can see here in this table. And if we look here at this graphic, and if we look at urticaria as this purple color, you can see that it goes all ages around, from the very early ages, maybe except the first year of life where you seldom see the disease, although we may have a different impression from Masha that he probably sees children from the very beginning, but the big impact begins after 1 year of age and goes through all ages, as you see here. And when we go to the countries, we can go from Latin America to Asia, Europe. You see always this significant burden, this purple color here, going all these in all these countries. So it's really an important burden. Why is it such an important burden, chronic urticaria? You have already heard about the prevalence, the high prevalence of the disease. Anna has already explained it to us. You know, it affects more women than men and has a really important and high lifetime prevalence. Another problem we have already heard about is the delay of diagnosis. That is quite often more than 1 year, where patients spend suffering, performing unnecessary and expensive tests before they have the clear diagnosis. And also the delay of therapy is quite important. In a very, very recent study done by the Charité group, they found that even 54% of the patients are with no therapy, even though they have the diagnosis of chronic urticaria. Of course, another problem is that we have to control urticaria, not cure it. So sometimes this is also a burden for the patients when we tell them that there is really no cure. You have to control the symptoms of the disease. And the drugs, we have to control it. At least the first-line drugs, antihistamines, do not solve the problem in more than a quarter of patients. Sometimes in some studies, even up to half of the patients do not respond to this first-line therapy. Another problem is disease duration. You can have more than 10% of the patients still having urticaria after 5 years. And we know it can be long, the duration of disease, and the length of the time you will suffer from disease, you cannot predict it. Of course, there are some clinical data that can suggest that disease will stand for a longer time, like if you do not respond to anti-H1, if it begins after 45 years, if you have concomitant chronic inducible urticaria, if you have intolerance to NAIDS, or if you have a relapsing course. These are markers that probably your urticaria will last long, but there is no laboratory, no data that really will predict the duration of this urticaria. And when we look at the patient itself, the impact urticaria can have on the patient, the health-related quality of life, you see that about a third of the patients have a DLQI above 10, which is really a severe impact on the quality of life. And of course, we can use, and you should use during your appointments with your patients, you should use other patient-reported outcomes that evaluate quality of life, like QQOL or angioedema quality of life, or other instruments that are being used for chronic inducible urticaria. They are being validated for chronic inducible urticaria. For the moment, we have cholinergic quality of life questionnaire, but this is important. And what do these, the response to these questionnaires tell us how these patients suffer and how their health, their quality of life is really impacted by urticaria. These are some of the aspects I will tell you that will really impact the life of these patients. One is unpredictability. The other is itch and severity of wheals, angioedema, and concomitant CINDU, or some of the aspects that really impact this. When you see a patient like this, especially the one on the right with angioedema, they can wake like this without any predictability when it will come. And so the question is, when will I have this? Will it be on the day of my wedding, on the day of my exam, when I have a job interview? So this is an important question they have to ask them every day. Another question, where will it come? Will it come in my face, or will it be hidden? It can be important, and they never know that. How long will it stay? Just a few hours, or will it stay for a week, every new lesion every day? So these are important questions that do not affect the patients because they cannot control their lives due to this unpredictability of lesions coming and going. Another important aspect is itch and the severity of wheals that you can evaluate by the urticaria activity score by 7 days. And what we see from this is that itch and also the severity of wheals will impact sleep. Not only the patient, but the partner will certainly have his sleep also affected, and parents will probably see it more from the presentation from Moshe. And of course, if you do not sleep, you'll have problems with school concentration, or if you have active lesions, it will be difficult to concentrate at school or at work. And this will certainly influence presenteeism and absenteeism, will not be able to go even to the work. And all these absences and will affect your school performance, will affect your career, will have an economic impact that we'll hear more about Luis that will speak about it. And of course, itch and wheals will also affect social interactions, sport activities, many other aspects of your life, even your sexual life, will be affected by the severity of these diseases and itch. Another factor that really has an important impact is the presence of angioedema. It lasts longer than urticaria lesions. It causes disfigurement, as you can see in this image. It causes pain, especially if it is over near joints. And it causes disability for many daily activities. This patient cannot see, cannot drive to work or to school. Sometimes they cannot eat when they have angioedema of the lips. They cannot walk or dress up. Or sometimes they cannot wear tight shoes. So many aspects of daily activities that will be impacted by this. And this is even more if you are concomitant CINDUs. Quite often these CINDUs, these inducible urticarias, they have quite low thresholds. For instance, if you have the solar urticaria, sometimes during the day it's easy if you go into the sun or go into the light and get the lesions. Or if you have cold urticaria, or if you have cholinergic urticaria, you have to run to catch a bus and you develop the lesions, or the temperature gets a bit higher, or you want to do sports and you cannot do it if you have cholinergic urticaria, because the lesions will come up and will really begin itching and disturbing you. So these patients with concomitant urticaria try to avoid the triggers, and this is quite important to limit their daily or social activities, so their life is really impacted. And also there are misconceptions that usually can impact the quality of life of these patients. One is that most people will say that chronic urticaria is an allergy. So people spend time looking for a cause, trying to avoid allergens, going through restrictive diets, limitations, which really impacts their lives. And another misconception is the risk of asphyxiation. Usually when even doctors, when they see an angioedema of the lips, they think, be aware you may have edema of the pharynx and you may be unable to breathe, so it may be life-threatening, which we know this is not the case for chronic spontaneous urticaria. So this should be clarified to our patients, because often with this fear, they are afraid of going to sleep. They try to stay awake when they begin having such an access. This is really important. So as a whole, these patients lose what we can call the joie de vivre, the capacity to be happy, and they develop other comorbidities like anxiety and depression. And in a study we performed in Coimbra, 40% of these patients have anxiety and 20% have depression. And in the recent study by the Charité team, affective disorders are present in more than a quarter of these patients. And I think it's interesting, the feelings these patients, how these patients report how they feel. It's the constant expectation, fear of suffocation, loss of control over their lives, embarrassment. They feel tired, weak, irritable, anxious. Sometimes they are sad, they feel discouraged, they feel frustrated. And especially they feel that other people's, even physicians, they underestimate their burden. It looks like the ugly duck. It's an injustice, I'm different from the others. So most of these patients give up. They give up medications and give up even the contact with the physicians. So it's really important. The question is what we can do to reduce this burden. I think we can raise awareness to improve the diagnosis and access to specialists. And I think it's important patient information and also early access to treatment. I think the work that UCARE centers have done with the Urticaria Day is really amazing. And in Brazil, we even have the week of urticaria. It's not a day, it's a week, it's 7 days of Urticaria Day. So I think these campaigns are extremely important to show the importance of urticaria, the burden, and how we can treat these patients and how we can help these patients. Also, urticaria schools and urticaria patient schools try to help the patients, inform them about the disease is very important, as well as leaflets that help him go through the disease, even though sometimes in the internet we find someone that is a condition that is caused by food and medicine. So we have to be aware of what is in the internet, and we have to try to change it to really give important information. So I think we have to talk with the patients. We as physicians have to talk with the patients, tell them we are not alone. And I just wrote this commentary about chronic urticaria. It's no more a Cinderella disease, as it was called 30 years ago. It can be called almost a rock star, especially when we go to congresses. We see the rooms full of people who want to learn more about urticaria. It's not the disease that no one wanted to know. So patients have to know that there is a lot of being developed about urticaria that is trying to help them, so that it's important that when we are facing the patients, apart from this, we explain them what is urticaria. It's not an allergy. Do not go on strict diets that even may have other harmful effects on your life. Tell them that urticaria can be severe and long-lasting, but not life-threatening. And we don't have a cure, but we have ways to treat you until it is gone, and we can have your urticaria quite well under control. And of course, we have to discuss with patients treatment goals and really discuss with them what they want best. And this is quite well introduced in the new guidelines, where you have to talk with the patients and assess diagnostic procedures, comorbidities, assess severity of disease, and be aware of the importance of patient-reported outcomes, and really adjust treatment. And we all know that we have good treatment. We have this good algorithm for treating these patients, going from antihistamines to adding omalizumab and cyclosporine, following the guidelines. And with this, I want to thank you. And I think I gave you the idea how we can help patients and remove this cloud over the patients and give them a blue sky to improve their lives. With this, thank you for your attention. And now I give the word to Luis Ensina from Brazil. We'll speak about the problem of the burden to the society.
Hello, everyone. It's very nice to see you all here. I'm very enthusiastic of this kind of activity. Thank you, Margarida. Obrigado. Thank you, Anna, for the invitation. My task here, burden of the chronic urticaria for society. We have a lot to talk about that, but we don't have so much time. So I'm going to give you this quick overview, and then we can discuss some specific points at the end. These are my disclosures. So in my opinion, I see that when we consider burden of chronic urticaria for society, we have to think about family life, work performance, not on the patient side, but on the company side or the society side, of course, the healthcare resources used, and the costs of the disease. So I'm going very quickly into each one of these topics, showing you what we have in terms of publications. We don't have so many data about all of this, but I'm going to show you some of them. For example, we don't have so many data about the impact of the urticaria in the family of a patient affected. I think that Moshe is going to present something regarding about urticaria in children and the impact in their families. But for example, in this paper from Hagip from Turkey, we see that the sexual functioning is frequently impaired in females with chronic spontaneous urticaria. We can see here on the left when we compare this with controls. And on the right, we see that this sexual dysfunction is present in 2 of 3 female patients, is linked to high disease activity, poor disease control, is more common in patients with angioedema, is associated with anxiety, depression, fatigue, and linked to impaired quality of life. But for example, what is this kind of impaired sexual dysfunction in family's life, in the husband or in the partner of these women? So that's a point that we should start to investigate a little bit more. We all know that chronic spontaneous urticaria impacts the work of the patients. And here we see data from Brazil. We see that there is a significant difference when we assess the presenteeism, which is that patients that can go to work, but do not perform well at work. And of course, an overall work impairment as well when we compare to controls. Let me change here, yes. So it's also important to see that it's not just patients with severe CSU that has this kind of impact in work, but also patients with moderate urticaria. And here we see in green patients with UAS7 from 16 to 27, and in purple, UAS7 28 to 42. And we see that the impact in absenteeism, presenteeism, overall work impairment, activity impairment is almost the same. There is no significant difference. So patients with moderate to severe urticaria have the same impact on their work. So here again in Brazil, we see that patients with CSU, they go more to visits to the allergist when compared to controls or to the emergency room. And this also has an impact in the overall cost of the disease. We can see when we check just for the number of visits to the emergency room in different countries or regions. For example, here in South America, we see that for around 40% of patients visit the emergency room around 12 times because of the urticaria, and that's too much. Of course, there are differences between these regions, but in general, the number of visits and the percentage of patients that visit the emergency room because of the urticaria is high, and we could reduce that with some ideas that I'm going to show you at the end. We have also direct and indirect costs of using health resources. In this graph on the left, we see that costs with laboratory, outpatient visits, hospital visits, and medication are the main costs that we have, but mainly medication. In the right, on the right side of the screen, you can see the indirect costs, and absence from work is very significant, but also travel to outpatient visit as well. So there are some studies about direct and indirect costs, especially in Europe, and we see some differences between countries. Like in Italy, we have this unit purchasing power parity dollars as 900 for direct costs. In France, it's higher. On the other hand, the indirect costs in France is lower than in Germany. So it varies among different countries, and we should have this kind of data in each country. When we check, this is very important. If we consider that the the most important part of direct costs of the urticaria treatments for the patient with urticaria is the treatments, medication, being more specifically. We can imagine that biologics will have a strong influence in these costs. But as we can see here in this table, the total costs of a patient being treated with omalizumab is almost the same of a patient in standard of care. So there are some variations here, but at the end, the cost is almost the same. We did an economic analysis here in Brazil, and we could show that the treatment with OMA is cost effective in the Brazilian setting. And this helped us to incorporate in both the public and private health system, the drug, which was a very important advance for us. Of course, there are some, especially regarding public system here in Brazil, we have some variations when comparing different states. We have a very big country, it's like almost a continent. But in general, we could, by this kind of study, show to the authorities that even a high-cost medication at the end of the day could be feasible and could benefit the patient without generating more costs to the system. This is some aspects related to disease burden for the society. This was a publication did by Margarida, and you can see that all of us here today were involved in this publication. But there are some aspects that Margarida already addressed regarding the burden for the patient, but we can also have the same for when analyzing the burden for society. The first one is the high disease prevalence, but also the long disease duration, lack of curative therapy, healthcare resources, both direct costs and indirect costs. So all of these are important points that we should address to improve this burden for the society. So this is those are my personal ideas to reduce the burden. They are very similar of those that Margarida presented. So I think that increasing awareness among patients, physicians, and society is very important. And these UCARE initiatives are perfect for that, as well as for training GPs, pediatricians, and specialists for faster and accurate diagnosis. It's also important to provide access to current and future treatments. We have a lot of new treatments coming, and some patients will benefit of them. But especially in the beginning, the costs are high. So we have to produce data to justify the use of those treatments. And also developing new therapies to treat especially those severe and refractory patients. And we have to generate data on burden of CINDU as well. We have some data on CSU, but not so many data on CINDU. So we should focus on that type of urticaria as well. So thank you. And now I'd like to move on to my friend, Moshe. Moshe's presentation is going to show some interesting data about the burden of disease in children with urticaria.
So hello, everyone. It's my pleasure to present the burden of chronic urticaria in children. For the sake of time, I'll try not to repeat in length points that have been raised by my colleagues here. And I'm going to refute my disclosures. I'm going to refute that common belief that small kids are small problems and big kids are, big problems. I'll show you that even in small kids, you have big problems, especially with chronic urticaria. And this is, I'm starting with a case because I'm a clinician scientist, so I'm always inspired by clinical cases. So it's a classical case that I see in our chronic urticaria clinic, 11-year-old with a diagnosis of chronic urticaria in the last 2 years, despite high dose of antihistamines, repeated use of steroids, ketotifen and anti-leukotrienes. And she was referred for assessment of potential allergy, no physical trigger, and whole oral lab tests, as you can see, are normal. So that brings us to the objectives to discuss the burden of chronic urticaria in children and present strategies that could contribute to reduce that burden in children. So first of all, the median age of onset of pediatric chronic urticaria is about 5 to 9 years. The most common type in about 80% of cases is chronic spontaneous, and a quarter of patients exemplify angioedema. Compared to controls, as my colleague mentioned, even in children, there is higher costs related to chronic urticaria, almost $2,000 on average. And it seems that that cost is increasing. And this is a systematic review that looked at the prevalence of chronic urticaria. And what I want to point out is, first of all, that in 4 studies where the point prevalence was compared over time, it was clearly shown that the prevalence of chronic urticaria is increasing. So there's one thing. And then, unlike common belief, you can see that the prevalence of chronic urticaria was actually higher in children than in adults. So I'm often very surprised when it is presented and people say, or some of the physicians think, that chronic urticaria is a rare disease in children. So it's rare disease in general, but it's as common, at least, as it is in adults. The other factor that can contribute to the burden of chronic urticaria is not only the prevalence, it's the fact that chronic urticaria is slow to resolve. So this is a study that we've done in a cohort of children in Canada, showing that the resolution rate for chronic urticaria is only 10% a year. And we found that factors associated with higher resolution rate in kids included high CD63 levels that reflect the basophil activation and the absence of peripheral blood basophils. And then if you look at CIndU in children, this is also a study we recently published. We saw that the resolution rate is almost less than 50% over a 6-year period. So even slower to resolve compared to chronic spontaneous urticaria. And again, more likely in children that presented with high UCT scores, elevated CD63 counts, as well as patients suffering from thyroid comorbidities. So the take-home message is that chronic urticaria affects at least 1% of children and is low to resolve, mainly in CIndU cases. Chronic urticaria affects not only children directly because they have hives, but they affect children when their parents have hives. So this is a drawing that one of my patients, an adult patient with chronic urticaria, brought to my attention. So this is her child that is 6 years old, reflections on her mother's chronic urticaria. So as you can see, when mama is hive, everything is bad and everybody's crying and feel miserable. But when mama does not have hive, everybody is happy. And it clearly affects the atmosphere at home and the setting at home. So that's regarding the patient. So chronic urticaria is not that rare in children. It's slow to resolve. What about the diagnosis? There are also burden related to the diagnosis for patients and for physicians. So I know that many of you probably have seen referrals from, in that line. So this is like a 12-month-old. We're speaking about, rare disease in children, but we see often also babies coming with chronic urticaria. 12-month-old recurrent hive, please assess for dog or cat allergy. And then 6-month-old female, growing and developing well with recurrent hives, happen in the swimming pool, sometimes after nap, before starting even solids. Please consider allergy testing. Or a 12-year-old female with 6 episodes of general hive this summer, lasting days, happened when going to the woods, very pruritic, mostly on the buttocks. Please help identify trigger. So that's another cause, I think, for burden, both for the patients and the caring physician, because first of all, there are high expectations here that we will find an external cause from the patient, and they cause false expectations also by physicians that are waiting to see some answers and revealing a culprit. So despite the fact the new autoimmune mechanism underlying chronic urticaria revealed that in most cases it is related to autoimmunity or an internal trigger, there are still patients and caregivers that are often led by false expectations that will find a trigger for chronic urticaria. studies reveal that the presence of positive skin tests for both food and aero allergens are not related clinically to chronic urticaria. And this is clearly reflected in the guidelines. When we have recently published guidelines, we recommend against routine diagnostic measures in acute spontaneous urticaria. Now, burden can be related, so we said, to the epidemiology, the low resolution rate, a high cost, challenges regarding diagnosis, and also management, because we know that the management algorithm in children is extrapolated from adults. And we follow the same guidelines of, starting high dose antihistamines, and if that doesn't help, we go to omalizumab and cyclosporin, and then short-term use of steroids. The problem that in children, this is extrapolated from adults, and there are no large-scale studies establishing the efficacy or the safety of these algorithms in children. So often we get questions, both from pharmacists and from patients: is it safe to give that high dose of steroids? Is it safe to give omalizumab? Is it safe to give cyclosporin? And we can see that in real life, often there's high reliance on use of steroids in children and in adults. So often, not only these guidelines are being doubted by caregivers and physicians, they're often not following them. And unlike the guidelines, give often give a high dose of steroids for long periods of time. So how could we reduce the burden? First of all, heavy consensus guidelines among experts, managing knowledge translation activities among families and physicians, and having better management strategy that will benefit our patients. So speaking about consensus guidelines, so we have that. We've recently updated them. They're continuously being updated. We have lots of knowledge translation activity with the UCARE conferences. We have a UCARE centers. We have lots of talks, lots of webinars. We have podcasts. We have the Hive platform in Canada to share knowledge about patients with challenging chronic urticaria symptoms, and updating physicians and caregivers for the most updated strategies regarding the management of chronic urticaria. And we have, of course, the UCARE Day. For patients themselves, there are very little knowledge translation activities. We tried to develop such a knowledge translation activity by providing or generating a video for patients in our clinic to explain what chronic urticaria is and how it's managed. For the sake of time, I will not show you the entire video. I'll just start it and then progress. So this is a video that we show to our patients when they come to the chronic urticaria clinic. I hope you can hear that video. If not, I'll just so a child that raised up with hives. So explaining again that it's not an external trigger that's causing hives. And how some parents go to the extremity of avoiding almost all external triggers. Explaining the different kinds of urticaria, what's the difference between an acute one and a chronic. So going very briefly for acute urticaria, physical urticaria, and the most annoying form, which will be the chronic spontaneous. So I'm not continuing with the video because it will take too much of our time, but it's basically a 5 to 8 minutes video. And we've already assessed the effect of that video on patient, and this is an abstract will be presented in the coming AAI meeting, showing that there is an improved knowledge after watching that video. And our aim will be to see how much is retained And we're aware of the fact that many people will forget stuff, and education is a continuous process. So it will not be a one-time video. It will be presented to patients whenever they come to the Chronic Urticaria clinic, and would help, I hope, manage the patients more efficiently and more promptly. And I just want to finalize with new strategies, because as my colleagues mentioned, some of the urticaria patients will not respond to the usual or standard dose or even higher dose of second-generation antihistamines. So we need to target better the management of chronic urticaria. And there are a lot of exciting management strategies that are coming, targeting both mast cells, B cells, T cells, eosinophils, and basophils. The problem with most of these are that there are no large-scale studies in children. So in conclusion, pediatric chronic urticaria is a relatively common skin condition associated with substantial burden. Burden is related to the epidemiology of chronic urticaria, so it affects at least 1% of kids, and it has a low resolution rate, especially in CIndU. There's also burden challenges related to the diagnosis and management. In order to reduce chronic urticaria burden, knowledge gaps need to be bridged, and educational strategy needs to be implemented for both guidelines and KT activities. Virtual educational tools may be helpful, especially in this area of telemedicine, and future large-scale studies assessing new management strategies and better diagnosis and management approaches should reduce the burden of chronic urticaria and should involve more studies in children. These are my acknowledgements, and I would like to thank you all for your attention.
It's time for Q&A session. I would thank you very much for these three presentations, Margarida, Luis, and Moshe. The fact is that we have some people linked with us in this meeting, and there are an open question. There is an open box where you can send your questions. Now we have the first message from Emeko Katur. Thank you, Yor, for the great presentations. But there are many other friends linked with us, and we start to receive some questions. But my first one is for Margarida. Margarida, you've shown that after eczema, which is broad, and acne, urticaria is the third disease which really has the more impact from the cutaneous point of view, before psoriasis. And also you've said that there is a burden which is underestimated. That means people around who lives with the patients with urticaria underestimate the burden of the disease. Then what do you think about the fact that urticaria is looked as a stigma? That means the patients look themselves the disease and they feel stigmatized. You know what's a stigma. Yeah. And also this link with the fact that Luis mentioned about the sexual disability inside the family, between the couple. Okay, how the patients look themselves so bad and how they feel in the society. What do you think?
I think skin diseases as we can see them, and probably coming from ancient times where most skin diseases were contagious, when we come up with skin lesions that other people can see, people really feel embarrassed, feel ashamed of it seems it's their fault that they have done something that was wrong. So I think this is quite important and is really impacting them, probably due to ancestry that really relates skin diseases with big epidemics we had in Europe and in the world with the Hansen's disease. And so I think this is a big stigma for them. And probably, I think most people do not really understand the burden of disease. Neither your relatives, and what most patients say, not even the physicians understand how I suffer with this. And I think this is something important that we have to take care of, and to give this message to our colleagues that really urticaria is not something. I remember when I began being a dermatologist, there comes another crazy guy with urticaria, mostly a crazy lady with urticaria. It was related with some most psychiatric pathology, but I think we have really to understand these patients.
I remember an exercise that our patients did in Spain. They counted how many times the politics during a political campaign, they introduced the word urticaria, referring to a thing that was bad.
Yeah.
That means then they feel stigmatized, and you heard them how they explain it, then they really they hate to see themselves with a disease in an image. You know?
Yeah.
There is one question from Isabel Rosamino who says that, which is the principal reasons for the delayed diagnosis in CA0? You can, Luis, you can answer, and Moshe if you want.
Oh, okay, I think that the reasons may vary in different regions, but there are some reasons that are common for all of us. And maybe one of the most important is the lack of knowledge about the disease, not only by the patients, the public in general, but also among non-specialists. So at least here in Brazil, we see people going to the pharmacy, for example, with an allergy, and the guy from the pharmacy just gives him or her an antihistamine, in general, an old antihistamine, and then it doesn't work. And then this patient goes to the general practitioner, and they just change the antihistamine. So they don't know about the disease. Both doctors, other health-related professions, but also the public in general, they think it's an allergy that's very common, and they start to avoiding many different foods and all of that you know.
Luis, when the peoples go to the emergency area in Latin America with 40, you said 41% compared to the 29% in Europe, where they want, they are asking for some immediate treatment in the emergency area. They are looking for the corticosteroid injection or something like this.
Well, I think that there are some points here. The first one is that they want an immediate solution for their problem, so they go to the ER. The second is that the doctor that sees these patients have no idea about what's going on, so they give like 5 days of steroids, antihistamines, and that's enough. And when the effect of the drugs ends, the patients start to have symptoms again and go back to the ER. And here we have some interesting thing, like the patient has access to a private hospital. So they go to the emergency room to not pay for the consultation with a specialist.
Okay.
So they keep going to the ER.
Understood. I absolutely agree with you. I'm sure Margarida agree and Moshe agree that we don't have any idea about the burden on inducible urticaria. No idea. We don't have any idea. But you mentioned that in the cost, if we use omalizumab and the normal behavior without omalizumab, the total cost was not so different from the economical point of view. Where do you think is the difference? In the indirect cost, in the fact that cyclosporine is not so cheap, in the fact that omalizumab is not so expensive than other biologics, because it was really 27 versus 26,000.
Yes. Of course, this one was a specific study, but we did a very similar here. And I think that when you consider all of these visits to the hospital, to the doctor, the costs regarding transport, and everything else that involves the journey of the patient, the number the number of years that they stay without control of the disease, and this is repeating every year. So at the end, that's why the costs are almost the same.
Sure, incredible.
I think also
yeah.
I think also
Yes.
we have to consider the indirect costs, because these patients do not go to the emergency room, do not go to the physician, and they can be at school, at work. So the productivity is much higher. So you think about this. And also if you think about, for instance, cyclosporine, you have to do a lot of blood tests, and you have the problems, the secondary effects of cyclosporine if you use it. So these costs also have to be taken into account when we make the comparison between omalizumab and then other drugs that are not so effective or that need other control, laboratory control.
We can agree that there are a lot of patients still no treated and lost. Okay, that they do not want lost. That they do not want. There will be some treatment for them. Let's go to the last talk, because we are almost at the end, but we will prolong a little bit with the authorization of the organizer, at least for 5 minutes more. Moshe, do you mention that chronic urticaria in children is as frequent as is in adults? There is a difference in gender. That means it's more common in girls than boys. No.
No, it's equally distributed among sexes in children so far, most studies. And it's also, there's a question about breastfeeding and antihistamines. So as far as we know, the second generation antihistamine should be safe to use during breastfeeding, and very small amount is secreted through breastfeeding. So we usually don't tell mother to stop second generation antihistamine during breastfeeding.
Great. And you mentioned that it was longer, the course was longer in children, very, very long, especially if they were with cold urticaria. No, that means there is a special phenotype of children who start with cold urticaria even in the first year of the life, and it's very long. Then how? Let me know your opinion on this, and let me know how a pediatrician or a dermatology pediatrician can reach the autoimmune hypothesis in children, because you will not do an autologous skin serum test, and you will not do this invasive test. And how you approach this fact?
So the first thing that I tell the parents, first of all, it's not an allergy. It's not an allergic condition. You need to understand that your child developed to something that happened inside. Now, we don't know exactly what I'm telling them. Most of the cases is to substances that are secreted in the skin. That's why it's not dangerous. It will be limited to the skin. Often in children, it's after a viral infection or something that activates their immune system. There are not many studies in children, but as far as we know, the condition is a benign condition. So the good news, it will not be dangerous for a child life. The bad news, it can take a long time to resolve. So you need to be prepared. We have good management strategy to control it. So that's the first message I give to parents.
Will be useful to have some laboratory tool in order to address the autoimmune hypothesis, no? This is a challenge for the future. It's going as CD63 and this type of...
Right. Yeah, but these are expensive, tests and done mainly in laboratory, and practically they don't change the management. So I think practically speaking, I'm telling them, we have studies that suggest that it's an autoimmune condition, but doing that test for your children will not change its management.
In order to finish, you've shown a very, very nice video, and you mentioned, okay, we are in a society which is virtual. We are now in Zoom. We are now in a webinar. Normally, we do teledermatology. We have video conferences. And sometimes we don't have this tool, informatic tool, to explain our patients how the disease is through the virtual world. Then is a question open to Luis and to Margarida and to Moj. How can we approach to our patients, doctors, etc., which type of tools we need to develop, or do you need in order to improve your approach to your patients through this virtual world?
I think it will save us a lot of time to have that kind of tool. First of all, explaining and managing the expectations of families so they don't expect to do skin tests. So if you show them a video when they have chronic urticaria and explaining that it's something inside and not outside and it's not dangerous, then already you're in a different place when you start talking with these families. They know what your approach is, they know approximately what to expect, and they will not be disappointed when you don't do a skin test. So I think that will save us a lot of time and will help management.
Margarida?
Yeah, I think it would be nice if you could do such leaflets, or now in the virtual world, leaflets to put in the internet or videos that we could be organized by us that are really good, not some that I found yesterday in the internet, and that we could even show in the waiting rooms. We could have some films that were going as patients are waiting, maybe not only on urticaria, but atopic dermatitis, other diseases. We could do videos like the one by Marcia to explain to children, and others for adults to help patients understand what their disease is. I think if you understand your disease, and if people explain you clearly, you understand much better what is going with you, and you will engage in treatment much better. So I think it's really, information is mandatory.
Luis, you agree with that, I suppose? Yeah.
Yes, I agree. Totally agree.
Let's see. I think I will recommend also to go to the UCARE web, because I think some videos regarding the impact in the quality of life that Kanukalai from Kultanan from Thailand created are there. I really think we had a good webinar. Sorry for my few mistakes with my slides in the introduction. I will thank again very much Novartis to sponsor this webinar, and the UCARE LevelUp in general. And I hope that you enjoyed a little bit. This will be recorded, will be available for everyone. And I think that should be available outside also the UCARE network. Let's see how we can promote our disease, the knowledge of this disease among our patients, among the doctors, among the mass media in general. Thank you, Margarida. Thank you so much. Thank you, Luis. Thank you, Moshe. It was great. Thank you all for being here with us.
Thank you, Anna, for inviting us and for giving us this opportunity to speak about our disease.
Sure. Goodbye.
Thank you. Bye.